that there is a system they have put in place. If you want to see somebody behind you, there's a system that you use. Similarly, in the laboratory, you need to put up a system. So then you can define what is quality control. Quality control is a system, we have already seen that, system to monitor. Now, since you are talking about the laboratory aspect, we are talking about the system to monitor the analytical process. What do you want to do? Like in the case of Nairobi, you want to see whether the person behind you is a good one or is a lag. So here you want to detect and minimize errors during the analysis. You want to prevent reporting of erroneous test results. Now, there's a mechanism you have put. That system should be able to communicate to you. I didn't have time to talk with Elizabeth, with Gitao, with Wamaida, to know how their systems are able to detect errors. Supposing the mirrors are not showing you somebody behind you and there's actually somebody behind you, what do you do? Of course, the mirrors are not 100%. I'm sure when I engaged these guys slightly more, you will get to know their story. They will tell you how they are actually able to monitor. So those are the things we are going to look at. What system do you set in place? And the report that the system gives you, and then how you consume the results. So for us to do that, we'll be talking about the statistical analysis. We'll be talking about the established rules. We'll be talking about the laboratory charts. Those are some of the red lights. Because of course, we are not sitting in the laboratory, but it is your lab. So, and you don't want to consume erroneous reports. So what do? I set a mechanism, and that is a mechanism we are calling quality control. All right. So what are the consequences? Of course, we have mentioned one, misdiagnosis. Delay in treatment is another thing. Increased costs. If you let your control go out of control, to get back to control, it is very expensive. Very, very expensive. And quality control system is very expensive, and that is why it is usually given a lot of attention. So by the end of this lecture, I expect you to pick those red lights or alerts. What is a control? I know this is your first lecture. Later on, one of my colleagues will be telling you how to determine the reference ranges. And therefore, a control is a specimen with a known reference range. That's it. If I want to control creatinine, and I have a specimen here with a known reference range for creatinine, then I can use it as a control. The controls can be bought commercially. You can tell the suppliers who are supplying you the reagents to give you the controls for various parameters, and they can give it to you. You can also make it or constitute it from your laboratory. Just like my colleague will be talking about determination of reference ranges. You can pull the patient specimen, determine the reference range there, and then say it is between this value and this value, and thus use it. Where is this control used? The control is used to validate the analytical system. How do we do that? First thing that is done in the morning, like now it is 9, the head of laboratory in Kenyatta, who is a Mendik, has a report already from calibration of instruments and calibration of tests. Because the first thing that the laboratory did is that they didn't run tests. They ran the controls to see what values they get and compare the values from the control values that they have. So if anything is out of control, the head of laboratory medicine is already informed, and the clinics are getting that report now. Don't request for the following tests because they're out of control. So you explained this is out of control, this out of control, this out of control. So don't request the following tests. That is a report. That value is important. And then the same value is posted on a chart because, like I said, every day it has been happening. So that value is posted on a chart. Today is 25th. So if the laboratory has been keen, they should be having 25 values for this month of October. If the laboratory has been operating on a day-to-day basis, those laboratories that operate up to Friday, they should be having now, this is week 4, the first day of week 4, which is a 25th, they should be having a value there for date 25, week 4, for whatever reagent it is, for whatever parameter it is, maybe creatinine. So if it is a creatinine, they must be having some values, maybe 20 values or so for creatinine so far. So if you ask for those values, you can be shown. And the values also are posted on a chart so that you see how the flow has been over time. So for the last 25 days in October, how has the quality control been performing? If you look at that chart, you can see, because the values, of course, from a chart, day 1 to day 2 to day 3, if you connect there, you'll be seeing, and we'll be discussing about that chart shortly. So let's classify the controls. We can classify the control in two, either in several ways, but I have chosen to classify it into two: the internal and the external quality control. Internal quality control. What is internal quality control? Internal quality control is the one that you have, the one we have been talking about. I told you you need to run it to validate the system. It is the one that you have, you are holding it in your hands. The external quality control, it is not necessarily what you have, but it is what is monitoring the internal quality control. I want to relate this well so that you can understand. What is the utility of the internal quality control? The internal quality control is run daily, which I have already explained. Like now this morning, the value has been obtained and it has been done. It is also used to establish reference ranges. What we do is we want to know the reference ranges of a certain parameter. We collect controls and then we use it to run. Like I said, somebody will be discussing this at a later date. Validation of a new reagent. Yes, you get a new reagent, you get a new machine. You want to see what values it will be giving you. You use the quality control, and that quality control is the internal quality control. When the instruments break down, again, you stop doing the patient testing, then you repair the machine. When you repair the machine, you want to see whether it is okay. You use the internal quality control, and then you check if it is correct or it is going back to normal. So much about internal quality control. What is the external quality control? Like I said earlier, external quality control is not what you have. It can come or it can be invited. For example, the KNH may want to check if the values they are reporting for creatinine are accurate. So they will pick a specimen, send it like a patient specimen to a place like Nairobi Hospital, and they tell them to report or to give them the analysis. That is what you are sending is the quality control material, and the value you want to check if it is okay for you. Uh, Sorry, give me 1 second. I want to answer an emergency call, then I'll get back to you. Just 2 minutes. Hello? Hello? Sorry, there's an urgent matter that I needed to attend. I hope we'll be able to attend it as we move on. So then you come to external quality control, and I said I've given you an example where you source for the external quality control. But there is also external quality control that is not sourced, but that comes. Give an example, like you people, you're going to finish school, then you need to be licensed by the medical board. What you don't know is that medical board is not just seated waiting for you to come. Medical board will has assessors who go around. They come to University of Nairobi, they go to other places where medicine is offered, and they interrogate things. Give me a second again. Sorry, I'm back. Mm, Sorry for that interruption. Mm, what I was saying is that the medical board will go around. They'll come to University of Nairobi. They want to check the course, what you are offering, the kind of lecturers that are teaching you, and they will go through all these things to assess and to tell whether the curriculum that you are doing is that can produce a doctor in Kenya. That is part of external quality control, and the University of Nairobi must keep on, and any other medical school for that matter, must keep on vanishing that data up, current data on what is happening, the kind of things, the what, all that thing must be informed. That is a part of external quality control. Uh, you are going to graduate and your degree will be stamped ISO certified. And that degree, ISO certified, you may need to know that it is not a stamp of the University of Nairobi. In fact, the University of Nairobi has to keep on sustaining standards so that they keep that stamp. And for them to do that, then again, the owners of the stamp must keep on doing the assessments. They come to university now and then, sometimes unannounced, to check whether they are observing the standards that they say they are going to observe. Now, the long and short of that stamp is those of you who work in international organizations and you go to countries that do not happen to know Nairobi as a capital city, you may be able to tell them what Nairobi is. But what you may not be able to do is to tell them that you went to a university where you need a degree. Because the moment you give it to them, they'll see this quality stamp or the mark of quality, and that is good enough to tell them that these people, they went to a school, and in the school, this university has standards, and therefore you don't need to be able to explain to them. That is the component or the significance of the external quality control. Now, then having said that, what is it doing? What you must be hearing from me is proficiency. Proficiency. And the proficiency here means, are we getting the right thing? One of the aspects of establishing proficiency is the determination of laboratory performance by doing inter-laboratory comparisons. What do I mean by inter-laboratory comparisons? What I mean here is that, take for example, you may have seen those cases of COVID-19 tests. Okay, now in the case of COVID-19, if you remember, we used to hear that there is a lab that will tell you are positive, another lab tells you are negative. Then you would wonder, okay, what happens? Who is telling the truth? Somebody has said I am positive, the other one has said I am negative. So who is telling the truth? Now, that may have told you something about the inter-laboratory comparison. Who was supposed to give us that to help us there? It is external quality control. They needed to create a way, a mechanism that the laboratories are operating on a platform that they are reporting similar. If you remember, we used to hear that, us, we are testing this parameter, we are testing 21 parameters, another one saying those ones are testing 17 parameters. So then the question, of course, is what is what? Am I positive or am I negative? What is what? That is what the client wants to hear. But then the client doesn't look at the number of parameters that you have tested. It doesn't need to look at the technique. You can't stand on people and tell them this is the highest technique, this is the best of the techniques. You can't say that. So it is the external quality control that has to compare and then set the standard, and then we use that platform so that when you go to lab A, you are negative, lab B, you are negative, and any other lab, as long as that platform is followed. Joint commission requirements, this one is standardizing. Like I mentioned, an example of Mendicom board. A Mendicom board is regulating so that a doctor coming from whichever university is licensed, dependent on the standards. Now the standards are set. So the external quality control will help us to set standards that will now regulate, and you also enter into international organizations or associations regulating the profession. Integration to routine workload. This will help you to know who you are giving or what assignment you are giving who, so that certain people are not overloaded and other people are not given less work, to be able to utilize your personnel well. The ongoing evaluation of the test to correct unacceptable results. I've already given you an example of the COVID-19 results, which you all know. Employee competency. Like when I talked about the medical bond, they would want to see what is who are the lecturers, what is the qualification of these lecturers, who is the lecturer teaching what, and is it competent, is it what? That is now, if you look at that, we are talking about proficiency. What is the quality goal? The purpose of the quality, this is now an overemphasis, is to provide test results that are correct. They are valid. They are within the expected limits. Don't tell us this person is positive in lab A, is negative in lab B, is indeterminate in lab C. Give us the correct, and that is the goal of quality. And that's what are they interested in? They're interested in the procedures, so that when you are told, when this laboratory is testing this, the procedure is clear, detecting problems, then correcting the problems, and then making statistical procedure for monitoring the analytical process. Coming to proficiency testing, what we have called the external quality control. What is the significance of the proficiency testing? Or broadly, external quality control. Broader monitoring of other dimensions. They want to check, like already we have talked about I've given you example of COVID-19 tests. Broader monitoring, what is happening there? What is happening here? What is the platform that we are using in the country? What is the turnaround time for the tests? They look at those dimensions, this and that and that and that, all those dimensions, they are able to be brought. Testing dimensions. Customer satisfaction. Now, when quality control created started talking about the COVID-19 tests, of course, there was hue and cry. Then they established the National Reference Lab. Nowadays, we are not hearing about COVID-19 positive, COVID-19 negative. The customer is satisfied. The external quality control is supposed to tell us the specificity, sensitivity, the parameters in a nation, the changing dynamics. So the customer is ever satisfied in the laboratory. So that now when the external quality control hits in our hospitals, then we know that what we get in Nairobi Hospital is reliable. If you run to Kenyatta National Hospital, you get similar results. You get another similar results in another hospital, and then it becomes something that the customer is satisfied. Even turnaround time, they ensure the turnaround time. Creatinine will take how long? It will take 10 minutes. If it takes 10 minutes in Kenyatta Hospital, if it takes 10 minutes in Nairobi Hospital, it should not take 30 minutes in Aga Khan Hospital. So the turnaround time is regulated. Accreditation. It is where we create a platform upon which our laboratories should operate. Then we make them subscribe to it. So if you are subscribing to us, you have met certain standard hallmarks, and thus you are accredited. You say we can give you a license to operate on our platform. Patient preparation. Like now, COVID-19, patients know what they are going to go through in the process of specimen acquisition. Uh, if it is like bleeding, no, it is standard. You will not, you cannot get to a lab A, you get a different preparation from lab B, you get to lab C, you get to lab, it is standardized. Patient preparation, acquisition of specimen, etc. All these things. That is now the significance of the proficiency testing. Coming to internal quality control, what factors should you be concerned so that now you get the valid results? You got to be worried. Remember, we said at the end of this discussion, I want you to highlight the hallmarks, the areas that you need to be concerned so that you get your end lights. Wow. Outside the laboratory, there are factors that are there. Within the laboratories, there are factors that are there. All right. So outside the laboratory, you can see, if you're looking at the diagram, you can see outside the lab creates a greater area or avenue for incorporating errors compared to internal to within the laboratory. Now let's give it a little more attention. These variations or the sources of errors can broadly be divided into two, where we have clinical and analytical variation. Now, what are the clinical ones? In clinical, I can divide it into two. If you are looking at the left-hand side of my slide, that column talks about the clinical variation, inter-individual and intra-individual variations. Inter-individual variations, they are clear-cut. You can draw a line. Age, sex, race, genetics, long-term health status, like HIV, like diabetic, like, and so you can draw a line in between. You can tell between an old and a younger person. You can tell between sexes. This one is clear cut, and those factors that affect the results, you can always be able to identify them across gender. For example, if I'm reporting hormones, then I know that I've got to refer from different ranges for they are sensitive to sex. If I'm looking at certain parameters, like maybe again, I've got to look at the age because they change across age. But there are those also factors that are not clear cut, but they also affect the results. These are what I'm calling intra-individual variations: diet, exercises, drugs, sleeping patterns, posture, time of acupuncture, length of time that tonic is applied. These are relative, they are not clear cut, but also you need to question them, or you need to so that they don't affect your results significantly. That is clinical variation. Coming to analytical variations. Analytical variation is broadly divided into three. There are those variations that occur before the tests are analyzed or the samples are analyzed. That is what we call pre-analytical errors. Then there are those errors that can occur during the analytical process, and that is what we call the analytical. There are those that occur after the test has been done, that is post-analytical. So now let's look at the analytical process keenly. And this is just brief, but I wanted to look for a way that I can be able to summarize so that I don't give you huge tables and then list the errors. I wanted to put us something that can help us to reason. And this is what I came up with. You are sitting in the clinic. A patient, of course, starts at the clinic. Then they tell you their symptoms. You raise some questions. You want the opinion of the laboratory to reach out to your diagnosis. So you collect the specimen, you write the test order form, you send it to the lab. The laboratory will process your question and give you back the report. That is what happens on a day-to-day basis in in the hospital. So then, that query and the generation of the response has steps. And in those steps, that is where we get the variations. So let's look at the steps. Test ordering. Test ordering is one of the steps that the first step. The only thing that you do here, you fill the test order form. But are there variations that occur during the filling of the test order form? Yes, there are. And I can broadly say they are related to omissions. You forgot to write the name of the patient. You forgot to write the test order, and you forgot to write the specimen taken. You forgot to write the dates. You forgot to write the gender, the name, the age, the what. Omissions. The other error that can occur there is omission. Rather, is when you write and it happens that you are the only one who can read your handwriting. Specimen collection. 5 things do happen. One is you choose the specimen you want to collect. 2, you choose the specimen collecting container. Thirdly, you label the specimen collecting container. Then determine the quantity of the specimen you want to collect. And lastly, you collect the specimen. So what variations do you get here? You get variations related to insufficient quantity. You get contamination during collection. The specimen also may change quality because it can be hemolyzed. You can also collect the specimen with other interfering factors like it can be proteinic, it can be icteric, it can be lipemic. Wrong specimen. You can collect some specimen, but it happens that it's not for what you are collecting it for, among other errors. And then from there, you transport your specimen. Transporting from now your clinic to the laboratory, there must be a way of transporting. Possibly you use a messenger. But then during the process again, there are certain errors that can occur. The delay is a clear one. You can also get specimen transported in temperature that is not consistent with the requirement. For example, the specimen is supposed to be transported in a cool box and somebody is just holding it. Contamination can occur here, breakage, spillage. The specimen can also be lost. Despite the delay, it can also be lost completely. Those are some of the challenges with the transport. And getting to the lab, we come to the reception. In the reception, 2 things will happen. One, the specimen is baptized. What is the baptism? The baptism is laboratory number. It is given a laboratory number. And I need to state at this point that if you walk into a lab and you find a specimen without a laboratory number, treat it like you have met a stranger. The entry to the laboratory is a window. It is never a door. And the moment the specimen enters through the window, then that is where baptism occurs. Immediately, laboratory number is given. Once they get the laboratory number, then it means that from there, you can move on. Then the next thing that happens is that the specimen is booked in the laboratory book. 2 procedures at the reception. So the errors could be omission. The errors could also be that the specimen is not booked in the laboratory book, or laboratory number is not accrued to it, and therefore is left out. So those are some of the challenges that can experience. Now it so follows that the errors that occur between the testing, ordering, specimen collection, transportation, reception, that is what is called pre-analytical errors. Then coming to the lab, you have analytical process. Analytical process. Here, the errors could be related to things like missing out the reference ranges, rather not reference range, but the quality control could also be left out, expired reagents, over dilution, the contamination. These are some of the things that can occur during the analysis. Then the errors that occur during analysis are called analytical errors. From there now, any other error that occurs here is called post-analytical, that is reporting, transport, and interpretation. If you are still following on my chart, reporting, you'll think of errors like omission of reference ranges. Every test should have its reference ranges. You could also have illegible handwriting. Again, it has come. Transcription error is prevalent here. Transcription errors occur when the specimen is, either when you read a result somewhere, then you write a different value. Even in this lecture, I'm sure there are people who are hearing one thing and you are recording a different thing. That's transcription error. Then transport, you are moving this is now the laboratory trying to communicate to you. They are now transporting the results, not the specimen, and the results can be lost. The results can be delayed. They can be sent to a wrong place. The interpretation is another thing. Interpretation, this occurs when now it has landed onto your desk. All right, what happens when the results have come to your desk? You need to make use of it. And what you do is you have got to tell why did I order for these tests? But there can also be errors related to that. These errors include transcription error, which we mentioned earlier on. Here again, you can be copying results from your desk, either from the report to your diagnostic book, and in that case, it makes it you end up writing something else that is not what you have indicated. The worst thing that can occur is when you don't know why you are ordering that test. All right, now having seen that, we have now talked about the pre-analytical errors, post-analytical and post-analytical errors. So having seen that, this one I'll not go through it because we have mentioned it. Here, specimen identification, we have gone through it. You can check on the notes and see biochemical arrangements that occur during specimen collection, biochemical arrangements during specimen collection. I can leave it there for your reading. Special attention given to specimen, again, and biochemical arrangements if that does not happen. Hemolysis, which causes dilution, and there you can see the effect it has. I've highlighted electrolytes. There are also enzymes. Interfering components, I should have highlighted enteric, that is hyperbilirubinemia. The proteinemia, that is high levels of protein, and lipidemia, which is high levels of lipids in the specimen. These are some of the interfering factors. Animal antibodies, these again are likely to bring in and animal antibodies, they can interfere with the results as well. And this is occurring in the analytical process. Having seen that, let's now come to the types of controls. So we talk about the type of control. Remember, we talked about the sources of control earlier on, and we highlighted these things. Coming to the type of control, we have three major controls. There is what we call the high control, the low control, and the medium control. Like I said earlier on, my colleague will be talking about the reference ranges, so you'll be able to see the references where they come in. So high control starts from the highest value in the reference range to whatever high value you can achieve. So that the last value, the highest value in the reference range, is actually the lowest value for high control, and then going upwards. Then the medium control, it is a control that falls within the reference ranges, and then the control below the reference ranges is the low control. So you have those levels, the 3 levels. Now, I need to let you know that if you are doing research, it is accommodative to do the 3 controls. However, for routine tests, like again, you said controls are very expensive. So in that case, you don't go for it. You only do 1 control. For routine tests, do 1 control. Here, now, I don't know how many alerts you have picked so far. I'm bringing you another one. When a test is done, you take the tests that have been done over a period of time. And this one will be sent severally by my colleague. We'll be talking about the difference ranges. When you take several studies, several samples, and you run a common parameter, you look at those values, you come to realize that they tend to be clustering around a figure, which you call the central measure of tendency. And going through it, you look at, we can measure tendencies, centrality of tendency using mean. Of course, most of the values will be around the mean. Values start reducing as you move away. When you start measuring the deviation, you can look at standard deviation. For instance, minus 1 standard deviation plus 1 standard deviation, you can see some values around there. And they tend to reduce completely when you go towards the minus 2 standard deviation and plus 2 standard deviation. So that beyond 2 standard deviation, you don't get values there. That seems to consolidate a population. So then if that is done, what you get here is this characteristic. You have now the highest peak, which is the mean, and going outside now is the decreasing or the increasing number of standard deviation. On your left is the decreasing number of standard deviation, and you can see that forms a bell-shaped characteristic, which we call Gaussian distribution. This is now what defines the characteristics of any given population. All right. Now, how is that useful to quality control? That is where I'm bringing the 3 curves. I hope they are clear on your end. Curve A, B, and C. Look at curve B, curve A rather. Curve A is what we are expecting to see. Looking at it clearly, you'll see that the highest peak is at the mean. That is what we're expecting. It is closing at plus 2 standard deviation, minus 2 standard deviation. That is a highly controlled process, and the results that will come out of this system, they are valid, they are correct. Look at B. In B, you see that, you can see the closing is outside 2 standard deviations, minus and plus, and the curve at the top is slanted, it's not high, it's not sharp at the mean. That is an error. It is not the characteristic you want to see. What you are seeing there is that this one doesn't have, it is associated to a random error. A random error. Now, when it is a random error, it is associated to the change of technique, or it can be as a result of personnel. Random errors are highly uncontrolled, so you may need to look at what are the causes. Curve C. C it's giving us what we call systemic error. If you look at it clearly, it's more or less like curve A, only that curve C has moved away from the mean. So that tells you that the results are being multiplied by a factor. Okay, they're being multiplied by a factor. So looking at that, the curves, two curves, B and C, they introduced to us very key parameters in quality control: accuracy and precision. What is accuracy? What is precision? I used this diagram to illustrate this undarting board. The yellow things you are seeing are the darts, and the skull is supposed to be the central or the middle ring, otherwise called the bull's eye. You can see the extreme right, this player, and the darts scattered all over. If I tell you to determine where the other dart is going to fall, chances are that you'll not be able to determine. It can be anywhere. That system is said not accurate, not precise. It is called imprecise. Coming to the middle ring, that's where we are seeing precision, but skewed precision. There's some bias. You can see the darts are going to a common place. That tells you there's a problem there. All right. There exists a problem. So what we need to do is we need to correct that bias, so that is where we say you multiply by a factor, you divide with a factor, and then it goes back to where you want it. If you are to determine where the next dart is going to fall, most likely you tell me where it is likely to be found. Look at the first one. Now on my left, extreme left, you can see all the darts went into the same place, the bull's eye. We were targeting the bull's eye, we got there. So we have the valid, correct results. That system is accurate and it is precise. So now from there, I believe you can be able to define or to describe what the terms mean. Come now to processing data using the charts, using the published rules. If you give me one control, if I'm using one control, then I'll look at the characteristics, the standard deviation characteristics, and I'll use plus or minus 2 standard deviation as the marker. If the values are exceeding minus 2 standard deviation or plus 2 standard deviation from the mean, there is a problem. That is where I'm supposed to be alerted. If I'm using 2 or more than 1 quality control, then I'll use the published rules. For example, in our case, we'll be discussing Westinghouse multiple rule. So let's look at one quality control. I have talked about the random error earlier on. I've also talked about the systematic error as well. We'll be mentioning them again, talking about the shift trend. Now, earlier on, I said that the values of quality control, which are run every morning, which we call the internal quality control, they are posted on a chart. That chart, you join the points. Like I said, if you are to look at that chart today, you're going to be seeing day 25, and there is a value for day 25, which we can now join together. It produces a characteristic called the Levin-Jennings chart. Levin-Jennings chart. In the Levin-Jennings chart, what I do is I draw the mean. I identify the mean and I draw it there. Then I identify the the standard deviation plus 1 standard deviation plus 2 standard deviation, then minus 1 standard deviation minus 2 standard deviation. Remember, we said that here when you're using one standard, rather one quality control, then you look at minus 2 standard deviation, the mean, and the plus 2 standard deviation. So any value going outside 2 standard deviations is a cause of rejection. You start raising an alarm there. Then having said that, you look at this characteristic. You look at that, the second region, you realize that the second region has similar characteristic with the other earlier days, only that this one has moved out of the mean. If we multiply by an inversion of the same, or invert the points, the dots there, we are likely to get the same characteristic as here. So what are we talking about? What we are talking about is that this is an error where the results have taken a shift from the ordinary days. That error is called shift. The other error that we can get is trend. Those are not the two errors, the only two errors we can get. There are several errors we can learn from the Levin-Jennings chart. The other one is trend. You can see here the results have changed. They have now taken a different trajectory. They are almost becoming a straight line, but earlier on here you realize we did not start with a straight line. At this point, something happened and they started assuming a straight line. That error is called trend. There are several errors that I can list related that you can learn using the Levin-Jennings chart, but the commonest here is shift and trend. So much about one quality control. Let's talk about more than one quality control. And we said in our case, we are going to look at the Westinghouse rules. Now, Westinghouse rules, they are indicated in terms of figures and a value, or rather an alphabet, which is actually S. S is standing for standard deviation. Then the subscript numeral is the number of standard deviation, and the other numeral is the number of controls. Like now what you are seeing on your screen is 1, 3S, 1, 3S. What does that mean? The 1, 3S here refers to one control exceeding 3 standard deviation. The rule states you reject. You reject. 1, 2S, one control exceeding 2 standard deviation. That is a warning. And you see it has gone, you get alarmed, you raise a query so that you don't get out of control. 2, 2S. What you have is 2 controls, both of them exceeding 2 standard deviation. You reject the results. R4S. R4S. A group of controls, right? And that control is exceeding 2 standard deviation. There's a 4 standard deviation cumulatively. You reject the results. For 1S, you have 4 controls and they are all exceeding 1 standard deviation. Then you reject the results. Okay, this is a summary of the rules, Westinghouse rules. If quality is out of control, or quality control is out of control, what do? I said earlier on, you stop testing, you stop the tests. Then you repeat. Don't repeat, you correct the error. When you correct the error, you use the quality control to check whether you are back to control, and then if you are back to control, you start the testing. These are possible causes, which we have mentioned, we mentioned earlier on. And then from there, allow me to say thank you. Patel,
Yes, Doc.
I have now done my due duty.
Thank you very much for your time today in class.
All right.
If anyone has any questions, they can type it in the chat box or
Okay.
they can just unmute themselves and speak.
All right. That's okay. I'm waiting for questions.
Doc, I just had one question.
All right.
This is just something I've realized and picked up on. Quality control testing, like let's say of point of care devices, like let's say the handheld glucometer.
Mm-hmm.
Is
What's
it
the question?
possible to do assess the quality control of such devices?
Yes, you can. That comes slightly different. One is you can have a central lab that can be calibrating these gadgets before you release them to the patient. Some of the point of care uh, equipments are used by the patient, or they're also used by people who are not specialized in the area, like Mendik is not specialized in clinical laboratory sciences. You can have a central lab, like Kenyatta Hospital can create a division of control, which is now calibrating these gadgets that are being used by the doctors, like the glucometers, and also the patients, so that it is controlled at that point. The government largely can also create a mechanism of calibrating these gadgets so that after some time, like if a doctor uses a glucometer a period of 6 months, you take it back to be calibrated. These machines also, or the equipment, they have internal quality control mechanism so that when you're buying like the strips, you have some strips that are dedicated for control so that you are told to measure, run control, maybe it is colored pink or purple. Then before the patient specimen, you use the purple strips, get the value there, and then compare it with, or you get it within this range, then you proceed. There are those accompanying instructions. That's another way that control is made. The third way is that is the using the software. Currently, in the with the current technology, we have softwares that are dedicated to quality, and the quality control can be uh, controlled externally using the uh, information systems. Hope I've answered your question, Patel.
Yes, it makes
All right.
sense.
Okay. Any
Thank
other
you.
question? Okay. Seems there are no questions. There are no more questions.
Yes, Prof. Yes, Doc. There's none, so we can end the session here.
All right.
And I will come. I think we have a session next Monday.
With me?
Yeah, but just wanted to inform you. Next Monday we have the pathology cat.
Mm-hmm.
So could we plan probably in the afternoon?